Assalamu alaikum. This is our very last lecture on pharmacogenetics and genetic testing. So let's start with genetic counseling and define it. So let's start with genetic counseling now. Now, genetic counseling is defined as a communication process that deals with the human problems associated with the occurrence or risk of occurrence of a genetic disorder in a family. So basically, you have someone who is known as a genetic counselor who is an expert in both genetics and communication. And this person would sit with individuals or family members to allow them understand the genetic basis of their diseases, the diagnosis, prognosis, and the available treatment of that disease, and the genetic and the chance of recurrence. So basically, let's say someone with colon cancer, and this cancer is tested and found to contain mutations in the DNA in a DNA repair gene. So there is high probability of recurrence of this cancer in that same individual. So this would be communicated with that individual, urging them to retest and recheck for any future incidence of colon cancer in that individual. In addition, the genetic counselor would discuss the available options in terms of, for example, future pregnancy, genetic repair of genes, like using the CRISPR-Cas9, for example, and so on. Just the options available for them for the future. So there are different types of genetic tests. Okay, so but first, before talking about them, we need to differentiate between genetic testing and screening. So the idea of screening is that it's basically a random identification of individuals with a certain condition, marker, genetic variation, mutation, whatever. So what happens is that technicians would go down the street, for example, or go around people telling them that they would do a genetic test for them, and to look for a certain mutation. And they're looking for individuals having a certain mutation, for example. So it's like very similar to what people are doing right now with the COVID-19 and the coronavirus, where they do random testing to see who has a coronavirus, who's infected with the coronavirus without having any symptoms. So basically, the tested person does not necessarily request the service. It's all done at random. Now, genetic testing, on the other hand, it's not random. So it's identifying the marker, the genetic variation or mutation in a person, and the person requests this service. So this person would go to a specialized center that does the genetic testing and request the test to be done on his DNA. So these are the different types of genetic tests. So the thing is, with predictive testing, it's not that a number is given like done with the predisposition test. Rather, it's telling the person that they have a chance of developing that condition. So, predictive testing identifies people who are at risk of getting a genetic disease before any symptoms appear. So being predisposition testing, if it turns out to be positive, it does not mean that the individual will get the disease. It just means that this person is at risk of developing the disease, and usually a certain figure is given, like I said. Now, carrier testing is basically telling if individuals are carriers of a mutant allele or not. Okay, and the possibility of passing their mutant allele to their offspring. Now, newborn screening is basically, again, it's random testing for certain genetic mutations, including inborn errors of metabolism like phenylketonuria. So when is it necessary for a person to undergo prenatal diagnosis or prenatal testing? Basically, these are some conditions. If the mother is if the mother's age is advanced, there's a good possibility that she might give birth to someone with Down syndrome, or someone with a structural abnormality of chromosomes. In addition, if there is an abnormal result in prenatal screening, not necessarily genetic screening, rather if there is something that is clinically abnormal, looking by the based on ultrasound results or something like that. If there is previous child, or if there is family history with chromosomal abnormalities, or if there is a single gene disorder, then this is an indication. This is a sign that couples must do prenatal diagnosis or testing. Now, if there is also family history of neural tube defects or congenital abnormalities, again, this may require parents to undergo genetic testing as well. Now, if there is family history of undiagnosed learning difficulty and other reasons like consanguinity, recurrent miscarriages, poor obstetric health, and so on. Now, there are different types of prenatal genetic testing that can be done. Probably one of the most common is amniocentesis, where basically the cells or DNA are collected from the amniotic fluid at 16th week of gestation. Now, in this case, cells are cultured, DNA can be isolated and directly from the amniotic fluid and analyzed by PCR or FISH, for example, if there are chromosomes that can be isolated. Now, the problem with it is that there is a chance of miscarriage, up to 1% risk of miscarriage. Now, another procedure that can be done is chorionic villus sampling, where basically the chorionic villi can be removed without getting inside the placenta. So cells can be isolated, and these can be done earlier than amniocentesis. So at the 11th or 12th week of gestation, they can be removed. And chromosomes can, and as well as DNA can be analyzed, as well as biochemical analysis can be carried out. The problem is that there is higher risk of miscarriage than amniocentesis, up to 2%. Now, there are other tests that can be done as well, such as maternal serum screening. In this case, certain molecules can be analyzed, as well as DNA, chromosomal anomalies can also be investigated, or fetal blood and tissue sampling, but this is advanced. So, what can also be done is pre-implantation genetic diagnosis. So, individuals who want to go through in vitro fertilization, it can be done. So, fertilization can be done in vitro, and then at the 8-cell stage, 1 or 2 cells can be removed, and this would not affect the development of the embryo. And then PCR can be performed on the isolated DNA. Now, this can give up to 30% chance of successful diagnosis of any genetic abnormalities. Now, briefly, we want to talk about gene therapy, which is basically the idea of treating individuals by changing their genes. So basically, the idea is to to replace genes with normal ones, or to insert into the genome a correct gene. And this can be done by sending the gene that we want to replace, by sending a good copy of the gene via weakened viruses, for example, or it can be done via liposomes and so on. So this can be done again prior to implantation. Now, of course, there are ethical considerations, and but science is progressing with this idea. Now, the first gene therapy case was announced about 20 to 30 years ago. A young patient with deficiency of adenosine deaminase, which is important for the maturation of T and B cells. So she had immune deficiency. What happened was that the gene for adenosine deaminase was inserted into the genome. It was introduced via viral particles, or it was transferred via viral vectors and inserted into the genome, and it worked. It was successful. Now, later on, many attempts were done. Success was variable, and I do remember about 10 years ago there was a clinical trial for gene therapy done in Philadelphia, and it was stopped because it was terminated because the patient was injected with too many viruses or viral particles. The patient went into septic shock and died, so they stopped all cases of gene therapy. Now, is it possible to do it now or not? I'm not sure, but the direction is the use of CRISPR-Cas9 system for correcting genes. Now we'll keep an eye open on that. So let's talk about pharmacogenetics and pharmacogenomics. So what's the difference between the two? Pharmacogenetics is basically looking at inheritance pattern of drug response for drug response, looking at one or a few number of genes. Now, pharmacogenomics is basically looking at the same thing, except that we're looking at the whole genome. Okay, so we're not looking at specific genes, rather we're looking at the whole genome, and then at the interaction of all of these genes in manipulating or determining a drug response. So the idea here is that you have a group of patients and they're given certain medication. Now, not all of them would have the same response. Some of them, the drug would work, they would benefit from the drug, and there would be no toxicity. Now, others, the drug would work, except that there is toxicity in these patients. Others, there would be no toxicity nor benefit from this drug, and then for some of them the drug may be toxic without any benefit whatsoever. So how can we tell before we give a drug whether the drug would work or not? Again, it's all based on the genetic makeup of these people, and that's the idea behind pharmacogenetics. So basically there are variations in drug response among people, and it's not only genetics, but it can also be physiologic, that is renal hepatic function, for example. Ethnicity is really important, as well as age and gender. So these days, for any clinical trials, men and women should be involved, should be recruited in clinical trials. Even when we do research on animals, it is recommended that male and female rats, mice, or rabbits would also be experimented on. Now, there are other differences, morphometric variations as well, such as body size, body composition, BMI, body mass index, and so on. Now, of course, the type of drug, the dose, the schedule are all important as well, in addition to environmental factors. Now, in terms of genetics, well, it plays a major role, and this is the topic of this lecture right here. So basically, pharmacogenetics is the influence of genes on the efficacy and side effects of drugs. Okay? So, the idea is that looking at drug response and types of drug response, it appears that there are three types of patterns, or three patterns of drug response. These are, you have continuous variation among individuals, so you cannot really put them into groups or cluster them into groups. Rather, you have this continuous variation. You have responders, non-responders, for example, and so on. And this indicates that drug response is multifactorial. It depends on multiple factors: environmental, genetic, and so on. Now, for certain other drugs, drug response can take the shape, a bimodal pattern, and this indicates that there is a genetic factor, and you either the heterozygotes would behave just like homozygote individuals. Now, people with recessive alleles would have a different pattern than the other group. Or you can have a trimodal drug response, whereby there is differentiation between homozygous dominant heterozygotes and recessive homozygous. Now, an example of enzymes that are critical for drug metabolism and that can determine drug response is cytochrome P450 enzymes, liver enzymes. So there are different variations, okay? When it comes to drug response, you can have differences in pharmacokinetics, such as drug absorption, distribution, elimination, metabolism, and activation or inactivation. And you can have polymorphism in terms of drug effect, depending on number of receptors, type of receptors, maybe polymorphism, and target proteins. So let's look at polymorphism in one of the transporters known as ABCG2. ABCG2 stands for ATP binding cassette, subfamily G member 2. Now, this protein is a xenobiotic transporter. What is xenobiotic? It's a foreign drug, foreign molecule, synthetic drug, and so on. So what this transporter does is that it allows for entry of certain drugs, and it kicks out certain molecules as well. So it plays a protective role. Now, this is a protein that is needed in certain tissues and cells, like a bladder, for example, which is exposed to toxic material in urine. So whenever these toxic chemicals get into cells, ABCG2 pumps them out, protecting cells. Now, what cancer cells do is that they take advantage of this protein, they overexpress it, so that chemotherapeutic agents that get into cancer cells would be also kicked out, increasing cell resistance to chemotherapy. So what this drug does is that it induces multi-drug resistance. Okay, so whatever drug is given to cancer cells, these cells are resistant to these drugs. Now, there are different polymorphisms in this protein. There's one of them. Don't worry about details, but it seems to be involved in increasing resistance of chemotherapeutic drugs towards chemotherapeutic drugs. So what this polymorphism does is that it reduces drug transport and it reduces protein expression as well. And people differ in terms of polymorphisms in this protein. So let's talk about drug metabolism in a little more details, because it seems to be more important. So as you know, whenever a drug is given to a person, it goes through two phases in the liver. You have phase 1 and phase 2. Now, in phase 1, you have a chemical reaction, a modification of the drug by introducing a functional group, making the molecule as a whole reactive. Now, what happens in phase 2 is that you have conjugation of these chemicals with other groups like acetyl groups, glucuronic acids, and so on, making the molecule even more hydrophilic so that it becomes more soluble and easily excreted. So certain genes have been involved, or polymorphisms in certain genes have been shown to be to influence the metabolism of drugs and drug response. So an example is the molecule or the enzyme CYP2D6. Now there are different variants of this gene, and there are different alleles as well, over 50 different types of this gene, different alleles that can make the enzyme, they can render the enzyme inactive, fully active, decrease activity, increase activity, and so on. So there are a lot of polymorphisms, and this enzyme is very important in metabolizing a large number of chemicals and drugs. So it seems that studies have shown that there are three populations of individuals according to how they metabolize different drugs using this enzyme. You have extensive metabolizers, so these are normal individuals, and you have ultra rapid metabolizers, and you have poor metabolizers. Now what ultra rapid metabolizers do, or the way they handle this drug, is that they metabolize the drugs such as debrisoquine, which is used for hypertension. They metabolize these drugs very fast, so they become unresponsive to these drugs, and they require higher dose. On the other hand, you have these poor metabolizers that do not metabolize the drugs very quickly, and the drug stays for a long time in the individual's body, resulting in toxicity. So it's quite beneficial to know the type of metabolizers individuals are. So what clinicians do is that they give a low dose to the patient, and they wait for a few days, maybe a week, to see how they respond to the drug. Maybe they could increase the dose if needed. Now, so CYP2D6 is an enzyme that is not only important for debrisoquine, but it also metabolizes many other drugs. You don't have to memorize this list, but it's important in metabolizing antidepressants, beta receptor antagonists, phenacetin, and so on. Now there's another enzyme known as CYP2C9. This enzyme is responsible for metabolism of many drugs, including warfarin. Now warfarin is an anticoagulant, and it gets inactivated by CYP2C9. So what this drug does is that it inhibits the regeneration of vitamin K, preventing blood clotting. So people with excessive activity of the enzyme, the vitamin K epoxide reductase, they suffer from bleeding. So what this drug does is that, what happens with this drug is that warfarin is that it gets inactivated by CYP2C9, resulting in the formation of the inactive metabolite. Now, individuals who are poor metabolizers, who have low activity of CYP2C9, have warfarin being active for a long time, resulting in bleeding in these individuals. So again, that shows the importance of genetic polymorphism in drug response. Let's talk about drug activation now, because some drugs require activation, and examples include tamoxifen and codeine. Tamoxifen is a drug that is an ER antagonist, estrogen receptor antagonist, meaning that it inhibits estrogen receptor, and this drug is used in treating breast cancer. Now this drug requires activation by CYP2D6, again our enzyme, into endoxifen, and endoxifen is the active metabolite. Now codeine also requires activation by CYP2D6, into morphine. So again, genetic variation can determine response to tamoxifen, the anti-cancer drug, as well as codeine. So one of the enzymes that are important for drug modification that is not a cytochrome P450 enzyme is an enzyme known as N-acetyltransferase activity. Now, what this enzyme does is that it acetylates many drugs, including isoniazid, which is a drug used for treatment of tuberculosis. Now, apparently, there are two types of individuals. You have rapid acetylators and you have slow acetylators. And acetylation inactivates the drug. So with slow acetylators, the drug stays for a longer time in the patient body, resulting in the appearance of adverse effects. So these individuals cannot inactivate the drug, and they are more susceptible to adverse effects. On the other hand, you have rapid acetylators that metabolize the drug very quickly, removing it from the circulation and reducing its effect. So these individuals require higher dose of isoniazid. The problem is that if these patients are given a higher dose, then they are at risk of liver toxicity. Just to show you ethnic differences in acetylation of such drugs, notice these are the frequency of fast acetylators in different populations. Now look at these numbers right here. For example, with the Canadian Eskimos and Eastern Asians, Koreans or Japanese, 90% of the population is fast acetylators. But compare this to Egyptians. They look like us in a way. About 20% of them are fast acetylators. So ethnicity is important in determining what dose is best for patients. Another important enzyme is cytochrome P3A4. Now, this enzyme metabolizes many drugs, including some of the common ones like ibuprofen, acetaminophen or paracetamol, Valium, lovastatin, and so on. Now, let's focus on one of them, which is paracetamol. Now, paracetamol is metabolized by sulfation or glucuronidation. So either modification would make the molecule more hydrophilic. Now, some of the paracetamol can be modified by cytochrome 2E1, resulting in the formation of a reactive compound. Now, this reactive compound is quickly removed by glutathione. Okay, so it's not toxic anymore, but if it stays for a long time, if there's deficiency in glutathione depletion for one reason or another, then this molecule can interact with other proteins and nucleic acids in liver cells, resulting in toxicity. Now the thing is, here's a note, an important note, is that alcohol is an inducer and a substrate of cytochrome P2E1. Now this means that people who take paracetamol several hours after drinking alcohol are susceptible to liver damage, because they would produce more of this toxic molecule. Now let's look at some other examples. We have an enzyme known as dihydropyrimidine dehydrogenase. Now this enzyme here is responsible for modifying 5-fluorouracil, which is a chemical used in cancer chemotherapy. So removing it from circulation or inactivating it. Now people with deficiency of this enzyme who take 5-fluorouracil are susceptible for severe 5-fluorouracil toxicity. So before treating patients, preferably the activity of this enzyme should be measured.